Thank you for joining part 2 of SBIRT, Knowing About Substances Makes a Better SBIRT Intervention. This is a full 3-part webinar in 2 parts, trained by Michael Palladini, who has over 20 years of work experience in hospital, retail, and long-term care pharmacy. He currently works as a director of client services for a long-term care pharmacy provider, as well as an outpatient drug and alcohol therapist. He recently published a book called Drugs of Abuse from Doctors to Dealers, Users, and Healers, and his website is listed there also. Now I will turn this over to Holly Hagel, who is, again, the director of the National SBIRT ATTC, for a brief introduction. Holly?
Yes, thank you. As you're switching over a presenter to me, I'll take it over and then briefly show you our website. And okay. I'm going to go ahead and I'll launch the poll.
Yes. There we go.
Okay. So thank you guys for joining us for part 2, as Christine mentioned, and we have a few webinar polls. I just wanted to get an idea of our audience and what level of interest you guys have in SBIRT, if you are actually doing SBIRT interventions, and a little about your education or your field of discipline. So I will do that right now. I'll launch some of our polls. Okay. Our first poll question is, which field do you represent? And it'll give you the choices of mental health, addictions, physical health, education, EAP, or if you are representative of a field that isn't one of the choices, because we're only limited to 5, if you could put in the chat box or the question box the field that you do represent and how it best characterizes your field. So I'll let that run for a few more seconds, and this gives us an idea of the audience, A, on the webinar, which I think Mike will find useful, and B, to our reach, because we are a new Addiction Technology Transfer Center focused on SBIRT. And so people who may have known us from the past and who are getting to know us new through further dissemination, you know, this gives us an idea of who we're reaching. So, all right, I'm going to give it a few more seconds. I see everything's kind of leveled out. And I'm going to close the poll and share it with you all. So you should see that the predominant representative on the this webinar today is 55% addictions. We have mental health representation, education, slight representation from physical health, and EAP representation. So, and we asked that specifically because we have, you know, a collaboration, which I'll show you on our website, with NORC, who's done a lot of work on SBIRT with EAPs. Okay, so there's one. Let me do the second, or yes, the second of 3 polls, and this one just specifically asks you a yes/no question. Do you conduct SBIRT interventions? And just to characterize the responses, there's 133 participants on this webinar today. So those percentages, bear in mind it's for 133 participants. And I'm watching the percentage change. I'll let it go for a few more seconds. See, 75% have voted, so. All right, let me close that and share it with you all. So I think we have not quite 50-50, but fairly close. 78% voted of 135 participants now, and indicating yes, they have done is 44%, and 56% said no. So we see we have a mixed audience as well, who have various, will take this information, maybe apply it in various ways. That is also very useful for us to know how you might use this information. And I will go ahead and launch the third and final question. And this is for those of you who answered no to the last question. Do you see your agency using SBIRT? Agency or institution, if you call yourself like a system. So again, I guess it's kind of a silly question, but not really. I mean, from one side of it, you could say if you're on the webinar, you have some sort of interest in SBIRT. From the other side, though, having an interest in actually envisioning doing it are two different things. So, all right. Well, I think we've got our responses from those who aren't implementing but can either see themselves as implementing or not see themselves as implementing. So let me share that with you guys. We see 61% of the audience voted, of 137 individuals on the webinar. 72% said yes, they can see their agency using SBIRT, and 27% say no. So that just gives you an idea of who's on the webinar, number one, and who's using SBIRT, and as well, and so that was pretty decent distribution there. Almost half of you are using it and half are not. A little under half are using it. And then for this final question, for those not using it, more people say they can envision themselves or their agency using it, and some of you cannot. So we expect that. I mean, this is why we do webinars, right, to learn more, especially the knowledge of things, and see if we can apply it. Well, a little more, I mean, this webinar was not specifically about the SBIRT model, but I wanted to show you the context of the webinar. And I'll do that, and then right before I will turn it over to Mike. So we are federally funded, and hopefully you joined us for our very first webinar in November. If not, that is on our website, which I'll show you shortly. But this is the network website. The Addiction Technology Transfer Center Network is SAMHSA funded, and we represent every state in the United States. So every state has a regional center, and now we have 4 national focus area centers. I'm just going to focus right now on our focus area so that you will see there's a wealth of information that we've started to compile on SBIRT. Whether you're already using SBIRT or you envision that you're going to use SBIRT, there's something on our webpage for you. And I have to say that we can't really take credit for the webpage. We have to say that there's such a wealth of information out there, a momentum around SBIRT through SAMHSA-funded projects, through state initiatives going on, that this information is not ours, but we have collected it hopefully in one spot, and we are in the process of doing that. And we're doing that through building a suite of services. So this is the web page, and it's basic navigation as any other web page. And you could click here and see our suite of services, which our webinar series is one. There's technical assistance, information, online resources, SBIRT toolkit. So just keep this in mind following the end of this webinar, especially if you're newly thinking about implementing SBIRT. Come back and watch our pre-recorded webinar and come on other webinars that are out there. And if you're up and running on SBIRT, there's tools and resources here. The SBIRT alert is an occasional once or twice a month email alert that really synthesizes a lot of SBIRT information that's going on throughout the entire country. So we hope to see you on our website and have you subscribe to one of our newsletters, in particular the SBIRT alert. Well, I just wanted to get that snapshot of the audience, as well as say thank you to Mike Palladini, who, Mike, you've been outstanding presenting for us. You've done another webinar, and I wanted to thank you and say that you have just a really good nature about you. You know the content so well, and you know it really is tiring, we can tell, but your question and answer section has been the star of both webinars that you've hosted for us, because I think people, no matter what area of the field they're in, really have gaps in their knowledge about how these substances, A, physiologically work in the body, and B, their pharmacology. So you've done a great job, and we really appreciate it. I don't want to take any more time away from you, so I'm going to go ahead and let you take over the webinar. So let me share my screen with you, I think. So let me give you, stop showing up. Yeah, here we go. Change the screen. I'm going to change the screen right over to you right now. So Mike, can you hear us?
Yes, thank you. Can you hear me?
Yep, you sound good.
Great. Thank you again. I appreciate that. There should be the opioid screen up where we kind of left off the last time. And again, with the spirit of asking questions, which I feel is very important at any time through the moderator, if anybody has a question, please feel free to interject, or we can take some time out at appropriate breaks to answer some questions you might have, because I think that is extremely important in getting this information across and understanding it without leaving and trying to think of it later. It's best to ask, and we'll talk about it on the spot. If you recall, when we first started talking about this particular topic, we mentioned the 4 classifications of drugs, being the stimulants, which we spent the entire time on basically the last time. And now we're going to talk about another classification of opioids, sedative hypnotics, and then hallucinogens and dissociatives. So the sedative hypnotics are going to include hypnotic drugs such as the benzodiazepines, as well as alcohol, and then the opioids as well, each of these producing the paradoxical effect to the stimulation, as are called downers or depressants. So the presenting symptoms and effects on the patient that we're going to be discussing are opposed to the stimulant effects that we spoke of last week. And we ended the conversation last week. Someone had a question as to effects of stimulant use on the diagnosis of a child having ADHD, if that would have any effect on it. And I did a little bit of research, and I couldn't find anything that directly related stimulant use by a female, say, when she's carrying a child. Most of the information there tended to point to either genetic predisposition or environmental cues leading to someone having an ADHD diagnosis. It was pretty well split down that line. So prenatal type effects weren't really addressed in anything that I read. So I'm not going to say specifically if it is a cause. There seems to be other reasons, either genetically or environmentally, that leads to that diagnosis. So I did want to look into that, and before we moved away from the stimulants, answer that question that we left with last week. When we talk about opiates, or the opioids, which means opiate-like, we're going to talk about a class of drugs here that has really gotten a lot of attention nationally as of late, because when we talk about prescription drug abuse in this country, there are a lot of prescribed drugs that can be abused, but the ones that cause the health and social issues that we're experiencing now are really truly related to the opiates. And there are a large range of opiates that are available for prescribing and for usage by physicians in different scenarios. But really, to know them all is to get a little more specific on knowing the drugs we're talking about. But for our purposes, they really are going to all produce the same kind of effect, and we're going to look at those symptoms. They're going to be in varying severities because of the different strengths of these particular drugs. That being said, we've got this slide up here that shows how these opiates are categorized, and they're categorized by what we call directly from the opium poppy, or a natural source, semi-synthetic drugs, or fully synthetic drugs. And then the few antagonists down there are listed also, which are synthetic drugs. Morphine and codeine and then opium itself come right out of the opium plant. They are a naturally forming alkaloid or chemical that the plant produces on its own. Morphine is what we call the prototypical opiate, where that was the first one discovered, and that is the one that all the others are kind of gauged against as far as strength and therapeutic value. Semi-synthetic drugs are these chemicals that have been chemically altered somewhat by a laboratory working on the morphine or codeine molecule that we are supplied with naturally. Heroin, or diacetylmorphine, is a chemical analog, they say, of the morphine molecule. Oxycodone, hydrocodone are chemically altered versions of codeine. Oxymorphone, which is Opana's brand name, are chemical alterations of the morphine molecule, and so forth. These aren't all the ones listed, but these are the major ones that we have to be concerned with. And then we have fully synthetic chemicals, buprenorphine, fentanyl, methadone, which are chemically manufactured, do not resemble the morphine or codeine molecules, but act in a similar fashion in our body. And the antagonists as well, naloxone or Narcan and naltrexone, in the trade name Vivitrol or Revia, work on the same receptor sites in our nervous system, but act as full blockers or antagonists to the response. So the different variations of these chemicals from different sources are going to have different pharmacological profiles, meaning they can act more quickly, they can last longer, they can have a better affinity or attractiveness to the receptor site and have a longer acting effect in that respect. They can leave the body more quickly. All these variables are thought of in design when these drugs are put together and made available by a commercial product. The opium plant is shown here with the sap or the resin which comes out of it. That is the source of the opium, which then can be extracted and processed to give us morphine and codeine. And if you just follow like a flow chart, you could see the opium sap, which then produces morphine and codeine, which then produces heroin, oxymorphone, oxycodone, and so forth down the line from this particular product. There's just some photos. I like to throw a few photos in just to keep it looking a little better. There's some of the prescription products available: morphine tablets, Vicodin tablets, Tylenol codeine tablets, OxyContin tablets, powdered heroin, which can be snorted or injected based on someone's preference. And then again, as we talked about on earlier slides on route of administration and those effects, you will get different effects based on how these drugs are administered. The stimulants and the opiates being no exception to that. And that's listed here on this slide, route of administration, toxicity. I'm not going to go back and find those slides again, but for IV drug use with these products, the powdered heroin can be diluted with water into a liquid to be injected. But then you've got some of these pills that are not meant for injection use, which are crushed up, put into a syringe and injected, or they're crushed and snorted. And then you'll get all of those effects that we talked about: abscesses, embolism, hepatitis C, HIV, nose infections, sinus infections, all of that associated with how these drugs are administered, what route of administration they're used for. The mechanism of action of opioids is simply they are agonists for what's called the endorphin mu receptor within our nervous system. And the mu receptor is responsible for pain submission, for increased endorphin effectiveness and release, so the pleasure of these drugs is experienced, more dopamine release through some negative feedback mechanisms in our nervous system. So there is dopamine release, which lends to the rewarding feeling with the use of these drugs. The submission of the pain transmission is their true therapeutic value. So these drugs are going to be utilized with, excuse me one second, good, are going to be utilized for that particular purpose in blocking that pain response. They're also least toxic, at least not as toxic to the brain and body regarding the stimulant use that we talked about last week. So the physiological effects are going to lend to less toxicity. What we have more so is what we're looking at the bottom of this page is more social and behavioral toxicity. Long-term use of opioids can lead to social withdrawal, behavioral changes and patterns in their behaviors, criminal behavior to support the habits, all because of the tendency of opiates to lead to more of a tolerance-dependent state as opposed to a toxic condition that the brain and body has to endure. Not that long-term use doesn't have specific effects on the body, but overall they are least toxic, and the main concern is the tolerance and dependence that develops and requires more and more of this drug to be utilized. So let's look at some of the physiological effects and symptoms that are visible from someone who is using opiates. Obviously, pain suppression, that's the therapeutic value associated with opiates. Through their mechanism of action, affecting the mu receptors, they block our brain's ability to transmit painful stimuli from peripheral areas of our body, and therefore the pain impulse is not received by the brain, and we do not experience the pain. That is their true utilization. Other effects are what we would call some side or adverse effects associated with these drugs, meiosis or the pinpoint pupils. That is probably one of the first things that someone needs to look at when they're trying to assess someone's substance use or under the influence currently, is the state of the pupils, because that is a peripheral nervous system effect that is directly affected by these chemicals, where the stimulants cause the pupils to be extremely wide open. The opiates will cause the pupils to be rather small, what's called pinpoint. Lowered heart rate, lowered blood pressure, lower respiratory rates. Again, opposite of what we looked at with what the stimulants do. With the stimulants affecting the dopamine receptors in the certain parts of the brain, and then norepinephrine and epinephrine being stimulated, causing increased heart rate and blood pressure and respiratory rates. With opiates, we are not having that. We are having mu receptor activation, which translates to this lowering of the heart rate. Everything's slowing down, lowering of the blood pressure, lowering of the respiratory rate. The lower respiratory rate is the cause of fatal overdosing in most cases for someone who has used opiates, because the respiratory rate becomes so slow that the brain does not get enough oxygen, the heart does not pump as it needs to. As these rates become extremely slow, the rate does not supply enough oxygen and starves the brain basically, and other functions become compromised, and it becomes a fatal situation then. Less severe but still to be considered are the constipating effects of opiates. These mu receptors are throughout our GI tract, and therefore there is a relaxation of the gut and the intestines, where nothing seems to be happening. You don't get any peristaltic motion. Things just kind of come to a standstill through there, to the point where you may have some impactions. This can happen with as little as just a few days of an opiate for legitimate purposes. constipation is a situation that is most likely going to happen, and anyone who needs to take a prescribed opiate is usually, it's suggested that a stool softener or, increased water intake, anything to combat this effect of constipation. Urinary retention for the bladder musculature. A lot of people in treatment who are using methadone or opiates and can't urinate on demand. It's truly a legitimate cause because they are getting issues with urinary retention and they can't control that as well, and the retention is beyond their control, and it's tough for them to avoid when necessary. Cough suppression, that's a therapeutic effect. Codeine molecule will affect the cough center of the brain, and therefore it's used for cough suppression. We get some lax muscle tone from activating some of the skeletal muscular nerve endings, acts as somewhat of a muscle relaxer. Dryness of mouth, euphoria is listed there. The neuroreceptors associated with dopamine and serotonin can be affected as well. So we're going to get a euphoric type of feeling when these drugs are used, especially at higher dosages. Some side effects, additional side effects here, what's called hyperalgesia. Patients paradoxically experience more pain. The way I look at that is that people who have used opiates for a considerable amount of time have kind of desensitized their nerve responses, and then these responses when the drug will leave the system, if they're in a position where they haven't had any and they're not experiencing the full effects of the drug, pain responses rebound beyond the norm. So a lot of people in recovery or are trying to quit using opiates or actively using them and haven't had any can feel this higher, this threshold of pain that has been lowered, higher incidence of being oversensitized to pain stimuli. So these people end up going to a dentist, say, or some type of minor procedure where the normal dose of something is not going to help them. They are going to require more medication to get to the level that they're used to having to quiet this pain response. Orthostasis, hypothermia, urticaria, or itchiness of skin involving the histamine response. If you're sitting with someone and they're scratching at their skin and they can't seem to stop it, they've got excess histamine as a response to the mu receptors being activated. So that histamine response is causing the itchy feeling that they need to attack with the dryness of the skin forming as well. Hypothermia, again, lower body temperature, lower activation of glands to hydrate the skin. Everything's kind of slowing down. You're getting dry skin. People may be cold. Things are all slowing down, whereas we had hyperthermia with stimulants. Now we're in a situation where things are slowing down and people are feeling those responses. Bradycardia and tachycardia. When I saw this listed when I got these slides, I wasn't familiar with tachycardia being a response to opiate use. There are a couple medications that cause like a paradoxical tachycardia. I think Demerol was listed as one of them. But for the most part, we can expect bradycardia or a slowing of the heart rate when someone is under the influence of opiates. Itching of mucous membranes inside the nose, inside the mouth. Those membranes, again, get some histamine response and they feel like they're itchy. So the patient's going to constantly be rubbing at that part of their body to satisfy that feeling. Decreased testosterone in men has been an effect, an endocrine effect from long-acting opiate use in the system. And that is something that was recognized for a few years now. And the effects of decreased testosterone can be then extrapolated to low energy, depression, low motivation, low sex drive, low libido. All of that can be in one way or another, if you really try, tied back to lower testosterone levels. There's been some advertisements recently by a company that's pushing a testosterone product, and it's kind of like the newer Cialis or Viagra now, where perhaps you're not suffering from erectile dysfunction, but perhaps you have what they call low T. And if anybody's seen those commercials, they've kind of branded that low T symptom or condition, where that is something that can be easily, excuse me one second, go right ahead, that can be easily referenced and asked for treatment, low T, low testosterone. So it's come from something that was suspected could be an issue to a full-blown condition now that can be treated with medication. Osteoporosis, decreased muscle mass can also be, I don't know if that's not strictly attributed to low testosterone, but that could be an ongoing symptom or long-term symptom of opiate use. The social and behavioral effects of opiates, social behavioral toxicity, these are the types of things that I see when a client comes in and is looking for treatment, and for treatment plan building or for identifying someone's needs, where they need to go in treatment. These are the types of effects that are apparent from someone who has been under the influence or has been using opiates for a while. This lack of motivation. There's unemployment situations, which obviously could be an effect of lack of motivation. Lack of education, dropouts from school, crime, criminal record, a compulsive or impulsive nature leading to need for money. The opiates can be expensive, especially when you get into some of these street values of the medications. And to maintain that need or that habit, there's a need for money. And unfortunately, and I'm not sure if we're going to truly address it in enough detail, is the tolerance and dependence that develops with the use of these drugs, and the withdrawal symptoms that are apparent with opiate use. If someone goes, some people may make it 24, 36 hours without using, but then the withdrawal symptoms will begin to make themselves known, and they're very painful and uncomfortable. So the need for more medication, for more substance is acute. And to get that, there's got to be resources. So this perpetual cycle of avoiding withdrawal symptoms leads to the need for more medication or more drug and the resources necessary for that. So that's pretty much on a daily basis for someone who is really in a full-blown addiction to opiates. And family dysfunctions, because of all of these types of behavioral effects that could happen, can really cause a lot of upheaval within a family unit, where there could be lying, there could be stealing, there could be lack of motivation and unemployment, where the true cause is being hidden. So they really do cause quite a bit of social toxicity, if we want to look at it that way. I believe that's all of the information that we've got on opiates. If anybody has a particular question on a particular opiate or issue there before we move into the sedative hypnotics, I'd be glad to try to answer that right now.
Okay, Mike, I do have a couple written questions, and I think there are some people with their hands raised, so we'll try that too. The first question is, does misuse of methadone have the same effect on a person as overuse of opiates?
Overuse versus misuse?
Yes. Does misuse of methadone have the same effect on a person as overuse of opiates?
Well, I would say misuse of methadone would be not using it per prescribed protocol within a licensed program. If you're in a licensed program and you're prescribed methadone to maintain your abstinence and you're using it per the dose you're prescribed, that's fine. Misuse, I think, would be using it on the street or taking more than you're prescribed or so on. And yes, methadone is a long-acting, full-mu agonist opiate, so it would fall right into the category of not using an opiate properly. If you want to talk about not using opiates properly, we can lump them all together. The only caveat then is that, well, methadone is prescribed for opiate dependence treatment. So what's the difference there? There's really no difference. It's just that its chemical profile lends to the fact that it has a slow half-life and it stays in the body at just the right receptor activity and blood level activity where it doesn't provide the ups and downs or the big spikes and highs that some of the other fast-acting ones will. So it kind of lends to that, maintaining that stability well. But in other scenarios, if it's used for pain control, which it can be, and if it's used on the street as a recreational drug, then its effects and its issues and all the drawbacks and pitfalls with methadone are going to be the same as with any of the other opiates that we can talk about.
Okay. I want to know of the two kinds of opiates, man-made and natural, which of the two does more harm to the body?
I don't know about harm to the body, but the synthetic ones are more potent. So there is a need to administer them properly. So there's always a situation where if they're not used properly, the ability for one to develop tolerance and dependence and perhaps go into an overdose situation may be a greater possibility with the synthetics, since they do have a more potent profile to them.
Okay. Okay, I'm going to try unmuting this person and see if they want to ask a question. Charles? Yes. Would you like to ask the center question? Charles? Okay, I will remute that. Let me try one more, and then I will go back to asking the questions that people have written. Okay. Joe, did you want to ask a question? Joe New? Okay.
Seems like you scare them away when you open them up.
I know. Joe, do you want to ask a question? Yeah. I think a lot of times they click on that icon without realizing it. Okay.
Yeah, okay.
Here's another question. When clients are on methadone maintenance, how does taking benzos on top of the methadone affect them?
And that's something we can address as well, talking about this next topic. But okay. the benzodiazepine response leads to increased sedation and increased respiratory depression. So it kind of synergistically or or additively adds to the effects of the opiates, which alcohol will do as well. So once you add any of these sedative hypnotics, alcohol, benzodiazepines, to the system that already has opiate response in it as well, you're really building up to additive effects in the respiratory, lowering the heart rate types of arenas where the potential for fatal results becomes greater and greater.
Okay. Does the lower testosterone continue after opioid use is stopped?
That's a good question, because I believe that once that ends and the body has the opportunity and the endocrine effects on from the opiates are no longer in place, that depending on the age of the person and how long they've been doing it, that the body's ability to begin to manufacture testosterone sufficiently will return. Keep in mind, though, that that's something that starts to tail off as men age anyway. So you could have two dynamics going on there where you may never get to a point where you need to be solely based on age and some of the time needed to get back to that. So it's going to be a selling point that these manufacturers are going to say is that, you know, you may not get back there, or you're already beginning to lose that capability as you age, and you may have kind of pushed that process a little further. Or I don't know of any real data that says that, you know, that can't happen. So if someone has been using opiates from ages 19 to 23 and they quit, they're not a candidate really to go into testosterone replacement therapy. They should, over time, begin to regain that function.
Okay. What are the effects of taking antidepressants if the patient is taking opiates, low energy, depression caused by opiates?
Yeah, you'll see a lot of antidepressants used for people in recovery from opiate use, because the question is used simultaneously. Is there going to be an effect, or what is the overall effect? Let's just say that the overall effect is that the antidepressants are going to try to utilize neurotransmitter function that the opiates have kind of squeezed dry. You know, the use of serotonin and perhaps dopamine and mu receptor activation. So we're trying to kind of jumpstart a person's ability to use the neuron functionality of their brain with an antidepressant. In most cases, we've got some, you know, a good majority of mental health providers in the audience, and I've seen this for many, many people in drug and alcohol treatment, that once we've been able to eliminate the substance, the abused substance out of one system, that over time then the therapeutic value they're going to experience is truly a mental health value, because now we need to look at what's their baseline, what's their underlying issues that may have led to substance abuse. So now it's become a mental health case that's going to work hand in hand with a drug and alcohol case to maintain that abstinence, as well as work towards uncovering, you know, deep-set causes that may have led to that. The antidepressants are just chemical additives to the brain that try to reestablish a balance that may have been compromised initially, and then truly thrown out of balance by the use of these substances over some period of time. So that's their value.
Okay. There are a few more questions about methadone that, like you said, you'll be going over anyway, and where time is ticking away. So I've just got, I'll give you one more question, and then you can, we'll do the rest afterwards if you have time, okay?
Sure.
This one. when injured military are given the initial injection of morphine in the field, how much can they be given in hours and days before medical staff will need to begin weaning them off to prevent overdependence?
Yeah, again, I'm not I'm not a medical a doctor, but for pain relief, depending on the extent or area of an injury, they could be given a few hundred milligrams of morphine every 2 to 3 hours, and that could go on for a couple of days. I guess the key in that type of therapy is monitoring, the proper people in place to monitor someone's pain response. How are you feeling? How's everything healing? We're going to start backing you down, and it's not up to the patient to determine their dose. If the doctor says, okay, we've given him 1,500 milligrams of morphine for the past 3 days, he should be in a position now, everything's looking good, let's drop it down to 1,000 for a day, and then we're going to wean him down off of morphine over the next couple days. And then I want to go to a non-narcotic pain reliever, because I believe that his situation now doesn't warrant the ongoing use of a strong narcotic. The opposite of that is to continue to give someone a strong narcotic regardless of any feedback or the lack of getting feedback from the patient, sending them out of the care, out of the hospital, home with a unregulated supply or a month's worth or too much that it's in the patient's hands to determine how much they need. And a lot of people will continue to seek that relief and not allow their body to determine its true pain threshold. So they'll mask the pain because they don't really feel like, I shouldn't put it that way, but they feel that they don't need to experience that pain right now. Or, unfortunately, there's always those situations where the euphoric side effects come into play as well, and I deserve that. I like that. That feels kind of good, and start talking to somebody else who recognizes it, and we may start sharing, and that's just getting into severe situations, but just the lack of control kind of leads to these situations. So it's always going to be based on the individual situation, where this physician should be able to know and monitor appropriate pain relief by using narcotics, and have the integrity to taper it and stop it, and have appropriate alternatives in place at the right time.
Okay. I will hold these others until after the next session, because I want to be sure that people who have to leave, will get all the information.
Okay. Continuing on, away from the opiates now, but still a class of drugs that is going to lead to similar presenting effects are the sedative hypnotics. Now, that title says that these drugs are to sedate, and hypnotics are what in the medical community is termed for helping for sleep. So we can sedate someone to quiet them, to calm their anxiety for a procedure or whatnot, or we can help them to sleep. Alcohol falls into the sedative hypnotics field, category I should say, because it produces the same neurochemical response and ultimately the same symptomology as the other sedative hypnotics. Whereas, you see people who like to drink, they may get a little boisterous and rambunctious and feel kind of energized at first from alcohol, but alcohol eventually will lead to the sedating and hypnotic types of effects in the system. Benzodiazepines are the main category of drugs, apart from alcohol, that fall in this category that have gotten our attention lately because of their extreme broad usage by physicians. And the few that are mentioned there, the brand names of Xanax, Ativan, Valium, and we should add Klonopin to that, because it has truly made itself known as a popular benzodiazepine for prescribing and abusing as of late. Other drugs that fall into this category are skeletal muscle relaxers, Soma, Flexeril that are used, antihistamines. Vistaril is used quite frequently by psychiatrists to try to avoid some of the more abusable drugs. They'll prescribe Vistaril to help someone relax or sleep. Propofol, a anesthetic that gained a lot of notoriety recently, is a stronger anesthetic used usually for hospital use, but has found its way out into the general community as well. Oh, pardon me a second. A few pictures for you to look at. This is a 2 milligram alprazolam or Xanax. They call them Xanny bars or bars because of their bar appearance. They're formulated so they're scored so they can be broken into a half piece or broken into quarters, which would be a half milligram. So those are 2 milligram. You've got the brand name Klonopin here, the brand name Xanax. There's a lot of generics for these drugs, and they will follow suit with shape and coloration as well. The mechanism of use, where just to summarize for you, the stimulants or dopamine agonists, where they interrupted with what's called the dopamine transport system. I don't know if we talked about that enough, but by doing that pharmacologically, they will increase dopamine availability and all the effects of dopamine. The opiates and their mu receptor agonism, causing the endorphin or mu response, which indirectly leads to more dopamine being into the system. Now the sedative, hypnotics, and alcohol mechanism is what they are called GABA agonists, which means that they influence the gamma-aminobutyric acid, or the GABA receptor site in our nervous system. The GABA has a B and an A benzodiazepine receptor area. I think I've got a graphic here for you to look at that. Again, these are always oversimplified when you're trying to illustrate a biophysical response or some, molecular physiology. It always looks pretty cute and simple, but it's very complex proteins that we're talking about. But just how these things work is you've got your GABA, this whole big pink thing, or is a GABA receptor that's embedded in a cell membrane. And what happens is that these receptors have specific sites or specific protein analogs or protein strips that the different drugs or substances or chemicals will interact with. The gamma subunit, they call it, alpha, beta, gamma. They're all along here and have been identified. So at one particular subunit, the gamma subunit of the GABA receptor, a benzodiazepine is attracted to that. Now, the mechanism in general shows that once a benzodiazepine has started to become attached to the receptor site, well, GABA is a neurotransmitter in our nervous system, which is our inhibitory neurotransmitter that does its job for the most part to keep things in balance. But once a benzodiazepine is on the receptor site, the GABA neurotransmitter itself then is more likely or more inclined to bind to the receptor site. So the benzo kind of helps GABA do what it's supposed to do. It makes it more efficient. And when this happens, what they show here is a channel or an opening in the receptor site that allows chloride ions, which are in the bloodstream throughout our bodies, it allows these chloride ions to pour through the outside to the inside of a neuron within our nervous system. And when that happens, you've got too much chloride on the inside. The cell can't do what it's supposed to do. It kind of just shuts down. It's hyperpolarized. There's no activity then. That is how benzos, that is how alcohol works. There's an alcohol receptor site on the GABA receptor as well. So with all these in place, you get these cells just kind of getting swishy, wishy-washy. They don't do anything. There's no capability to transmit impulses. They are kind of shutting down. That's great if you want to go to sleep. That's the therapeutic purpose, the intention of these. But we see it in different variations of effect. Picture the person who's had 4 drinks, 5 drinks, 7 drinks, 10 drinks, or the person who has, instead of taking half a milligram of their Xanax, has decided to take 12 of them today. Now we've got all these neuron transmission kind of not working, which relates to some of the symptoms we're going to talk about here with lack of control. The key points about alcohol, again, it's working as a GABA agonist on the receptor site we just described, but it also can work as a serotonin agonist and an endorphin agonist. So there's some reinforcing properties with alcohol, especially at the initial lower dosages. So we're enjoying this, we're feeling good. Keep putting it in our system, the GABA activation starts to take over more, and we begin to get all these depressed effects that we're going to look at. Alcohol is toxic. It's the most toxic substance we can ingest. It gets into each and every cell in our bodies, and over long term will affect, to some degree, every physiological system in our body. Which one succumbs is an individual case, but it gets into every system that we can identify. At moderate doses of alcohol, we're going to get some disinhibition, some mild sedation, some mood swings, blood vessel dilation, heat loss or hypothermia, CNS depression. The heart, the pulse, the respiratory rates are all going to go down, and we can get digestive irritation from irritating the lining of our GI tract. Long-term use, heavy long-term use, they're all listed there. Blackouts. If someone is experiencing blackouts or reports blackouts, you can assume that they have been using very high amounts of alcohol. And to get to that point, they had to build up some tolerance, so they've been working at it for a while. Nerve, liver, heart damage, mental confusion and delirium, fetal damage, that's a well-known situation there. Impotence, severe CNS depression, possibly death. Medical aspects of alcohol use. You get malnutrition, you get malabsorption syndrome, you don't get proper absorption of nutrients, you don't eat properly, a lot of caloric value with alcohol, especially beer, so diets are not maintained properly. Ulcerations within the mucosa, cirrhosis of the liver, pancreatitis, pneumonia can develop. Delirium tremens, the DTs or the shakes, that's usually a withdrawal symptom. Convulsions as a withdrawal symptom, which really is the defining point of getting someone into medical detox when they're trying to get off of alcohol, because of the ability for convulsions to take place. And that goes back to, what's going on neurochemically when we've been sedating and quieting all of these nerve cells continuously, and now all of a sudden we have released them, and we get rapid refluxes of neurochemicals and ions that really cause overstimulation of nerve cells and cascades of nerve cells that don't know what to do with themselves, and that's what ends up causing the brain to go into hyperstimulation or convulsion. Accidents because of lack of motor skill control, and again, I guess they're really pushing the impotency thing because that's in there again. More medical aspects, the esophageal varices and cancers and neuritis and gynecomastia. I've looked at some of these, and the underlying cause to a lot of these is an increase or blood pressure issues. After so long, we're going to get increases in blood pressure that is going to extend itself to these smaller vessels and cause them to break and cause issues to happen with our immune system in dealing with these broken vessels. So there's a host of medical issues that tend to start rolling in and happening to people in the long run because of their because of alcohol being involved with all of their physiological systems. As far as nervous system and brain or mental health effects, people become agitated when they're using alcohol for long term. Confusion, decreased awareness, impaired short-term memory, which again, I noticed when I was reviewing these slides that that was not listed under the benzodiazepine issues, and it certainly is something that we're going to look at a little further here, and I'm not going to see it. I might be getting ahead of myself, but remember here, and it's just, I guess it's a cue for me to say it right now, that impaired short-term memory is a strong effect with alcohol, as well as with abuse of benzodiazepines, or even the proper usage if someone continues to use them, that it shuts off certain circuits in our brain that are responsible for storing these short-term memories, and it doesn't work properly. So there's a lot of impaired short-term memory, and some hallucinations, especially with someone in detox from alcohol, or heavy use as well. Numbness or tingling in the arms, some pain, concentration or attention issues, and again, mood changes. So all of these things are maybe apparent or should be something to consider when doing some of these assessments, some of these types of situations that could be drawn out during a discussion. Liver disease, cirrhosis, hepatitis, fatty liver, the liver being responsible for processing all of this over the years tends to become cirrhotic, and cells die off, and you get some inflammation and disease and fat deposits storing. So the liver really suffers heavily from long-term alcohol use. If someone does have liver concerns from alcohol use, you're going to see abdominal pain and tenderness, which could be an acute situation, dry mouth and increased thirst. So that could be, something that might be overlooked, but if it falls in with a lot of the other symptoms that are being recognized, it could just be one more indicator that this is what's going on. Fatigue, jaundice because of the bilirubin, which is what jaundice is, because the liver is not processing it properly. Loss of appetite, nausea, weight loss because of improper nutrition, swelling in the legs, the ascites, in the abdomen, all of this again because of the blood pressure and the effects on the heart and the fluid accumulation within our system. Abnormal bleeding, bloody dark BMs, nosebleeds, gums bleeding, vomiting blood. These are all some pretty acute situations where if you're suspecting some alcohol use and this is going on, I don't think there'd be any need to hesitate as to what needed to be done. Abnormally dark or light skin, redness of feet or hands, spider-like blood vessels in the skin, easily bruising. Again, these small blood vessels losing their integrity because of increased pressure over time. And then the yellow color, again, the jaundice situation. Okay, benzodiazepines, again, depressant, sedative, hypnotic, used for anxiety control as well as insomnia. I think in the drug and alcohol and mental health field, we see benzodiazepines used a lot for maintaining anxiety and as an adjunct to in depression. they are sedative and hypnotic in nature, so you will get drowsiness. You can get dizziness from routine doses. It does not have to be an abusive dose. Lack of concentration. Again, stick in here if you're making any notes. Impaired short-term memory, which is key to if you're suspecting that someone is abusing these and their recall is not what it needs to be, then you can really suspect that they're really abusing these benzodiazepines. Decreased alertness, which is obvious. Certainly don't want to operate any automobile or equipment under the effects of benzodiazepines. Depression, whereas that might seem odd that we're using benzodiazepines in someone who may have a depression diagnosis, but the long-term use of these can exacerbate or worsen a clinical depression. So they're really not indicated for that as if we want to treat depression. And I don't think that we put these in these slides, but just to take with you, there's no authorized FDA-approved indication for benzodiazepine use beyond an 8-week period. Any of these benzodiazepines that are prescribed are for short-term diagnoses and use. There's no long-term approved use, yet we will see people who are at risk for abuse, perhaps from alcoholism or opiate abuse or whatnot, being prescribed a benzodiazepine indefinitely. So that is pretty much continuing and enabling them to continue to use an abusable substance. And all these other points here and highlight the potential for withdrawal syndrome, because there is definitely a well-documented and long protracted withdrawal syndrome with benzodiazepine use that has to be addressed properly. You cannot simply just stop benzodiazepines simply because of the effects similar to alcohol with the potentiation of convulsions. So people really need stepped off of these properly, depending on what they're using, a fast-acting, be it Xanax, a long-acting or Valium, intermediate-acting Klonopin. Benzodiazepines are categorized by how long they act or how long they last in the system, and therefore, what are they good for? If you're having a panic attack, you want a fast-acting benzodiazepine, and that's what Xanax or alprazolam was made for, and that's how it's indicated and marketed as a drug for panic attack. Valium is a long-acting for low-grade anxiety control. Klonopin, again, for moderate anxiety because it is a moderately acting benzodiazepine. That being said, because of its mixed profile, moderate, Klonopin has enjoyed a lot of popularity, but it's also extremely difficult to get someone off of them in an appropriate manner, because they do offer some immediate effects that people can enjoy if they take more and they stay in the system a long time, meaning the withdrawal syndrome is going to be protracted and difficult to get through as well. So it's not really the good choice that it's been kind of put out there to be. People switch from Xanax to Klonopin and they think they've made the best decision ever. It's really not that great of an improvement, and in the long run it's probably going to be even more difficult to get off of it. Some paradoxical or unexpected effects that you would see with benzodiazepines. People become aggressive, and I've heard firsthand accounts from someone who was using benzos a lot, or several people that they were pretty much subdued most of the time, but something could trigger them and they could explode into an aggressive rant, unprovoked, not understanding what's going on here. So, this paradoxical aggression can happen, and a violent outburst. I mean, it could be provoked as well, but there's lack of control on that. Impulsivity. If anybody's out there and has worked with a client who has retail theft charges or has had issues with kleptomania, not able to control themselves. A lot of times maybe it's just a coincidence, I don't know, but I've talked with several people who have fallen into that category, and they've all been under the influence of benzodiazepines. So, for example, a girl I know couldn't stop, and that's what her charges were. She couldn't stop from going into a store and just taking something, and she was always under the influence of benzodiazepines when that happened. Another gentleman I know held up a drugstore for more benzodiazepines under the effect of multiple benzodiazepines. So it's just that can happen. This short-term memory ceasing and impulsivity taking over, you get these situations where these unexpected behaviors occur. Irritability increases, and then it can lead to suicidal behavior, occasional suicidal behavior linked to this benzodiazepine use. I'm going to keep going here. There's a few more slides about some hallucinogens, and then we'll entertain as many questions as possible. The 4 categories again: stimulants, opiates, sedative hypnotics, and finally hallucinogens and dissociatives that we can throw in there with them. Classic hallucinogens that have been around for a long time, again, can be natural or synthetic. That's how hallucinogens are going to be categorized. There's been a lot of press lately on synthetic drugs that have kind of invaded the drug use scene, and they're usually going to be some type of a hallucinogen, synthetic marijuana, synthetic methadone, or the bath salts, a type of stimulant, but leading to hallucinogenic properties. So historically, we've had natural versus chemically synthetic man-made hallucinogens. LSD, synthetic. Marijuana, natural. Synthetic marijuana. Psilocybin or mushrooms, natural. Salvia, natural. Mescaline, natural. The dissociatives of ecstasy, PCP, and ketamine, and embalming fluid, those are synthetic or man-made chemicals. And they are all going to end up stimulating the NMDA receptor sites, which allow for that lack of connection to reality. If you want to look into that a little more, please do. In routine treatment models, I think we're seeing mainly marijuana use. You may see some ecstasy or some of the PCP or dissociatives used. There was an article in our newspaper here recently where teenagers were involved in a fatal crash because they were huffing a cleaner, a keyboard cleaner that has a fluorocarbon as its propellant, and they were huffing that and getting into this dissociative state. So when you get into some of these drugs that are inhaled or huffing, and I think there's a inhalant, there's a slide at the very end of this as miscellaneous, but they produce this blackout dissociative state that people find compelling, and they shoot for that. Marijuana, some general effects here, exaggeration of mood and personality, sedation or stimulation, depending on the set and setting, meaning who are you with, what kind of a mood are you in to begin with. It's going to determine how this drug ultimately affects you. Loss of sense of time, detachment, increased hunger. The increased hunger is the therapeutic value that has prompted a lot of medical marijuana proponents over the past years. Routinely, I don't see where you can really make a good diagnosis of someone through an evaluation of their marijuana issues by simply looking at some physiological effects like we've been talking about. It's certainly going to lend to a good discussion to someone. In my experience, and if you're all out there or can confer, I think you get into someone's marijuana history by just in this current day and age in the population that's using it is if you get into a conversation as to their thoughts on its legality or where it stands in our social setting right now. And then you can really start to get someone's history, thoughts, views, and true, genuine history from them if you just start talking about it in that context. They may show up and present with, you know, these effects shown here: impaired tracking ability, high dose psychedelic effects, difficulty with multi-step tasks, again, short-term memory impairment, statements to share with someone who may be hesitant to believe that there's any issues with marijuana, smoking producing lung irritation. Bloodshot eyes is one of the outward effects that is going to be very obvious. Increased heart rate. For some people, that can trigger what's called an acute panic anxiety reaction. So that could become important. A lot of people who have panic anxiety issues and may be trying to stay clean from another drug of choice discover marijuana and its acceptability these days, and it's less of a toxic substance than they were using. But they could run into these issues where, you know, some acute anxiety reaction or panic attack that is, you know, lying beneath the surface for them could be triggered from some marijuana use. So that might be a connection to make when you're trying to help somebody. It just basically it's used, it's inhaled deeply and longly. Over time, it could lead to emphysema and some lung cancer. The fact that there are withdrawal effects noted and historically documented would answer the question, is it addictive? Does it cause tolerance? That type of thing. Well, if there's withdrawal effects from stopping, then the logical conclusion is that, yes, it does cause a physical dependence, and it can be considered an addictive substance. So when people suddenly stop or try to quit or are forced to quit, they'll get some aggression that comes out of nowhere, some increased anxiety, depression, you know, depressed appetite. All that can start to accumulate when they begin to abstain. I'm sorry, I don't have anything to add to this slide of fetal effects in the reproductive system, and there's nothing here for me. And from my personal knowledge, I'm not aware of anything being documented that there are fetal effects or any effects on the reproductive system. And if there's anybody in the crowd that can answer to that or know of anything differently, marijuana is one big studied chemical that we've got years and years of scientific study under our belts with, and it's gotten even greater attention over the past 5 to 10 years with all of the medical and legal issues surrounding it now. And I have not seen anything in print or that's been proven that can say that there are some effects here. So I'm not going to address that because I'm really not an expert in that, and I haven't seen anything. So if there's something you need to find out about that, please do that. Burnout in quotes there. Again, I would say that's part of the amotivational syndrome that can develop with marijuana use. It kind of, for lack of technical term, it kind of drains someone's motivation, and because I think it does have a slight addictive profile, that it leads one through some of the serotonin and dopamine and cannabinoid receptors that have been recognized to crave more of it and want more of it and get into that behavioral pattern that is not associated with productivity and motivation and long-range thinking. So it kind of detracts from someone in that respect and would give them the label of a burnout. And miscellaneous drugs, which we kind of alluded to, the inhalants and solvents. You can use anesthetics, any volatile solvents, nitrites, some of these cleaners that we're seeing, all perfectly legitimate substances that are available that find their ways into usually adolescents' hands because of their legality and availability and their strong rush or high that kind of is very impacting, and they really feel it, and it kind of provides that rush, and that's attractive to that crowd. And then some performance-enhancing drugs are listed here. Again, we're not getting into any of the presenting symptoms of anabolic steroids or HGH, excuse me, but I guess for the purpose of this discussion, please be aware of them and note that they may have, as far as anabolic steroids go, there's going to be a domino effect of effects on someone's metabolic or endocrine system, and those symptoms can be documented and looked up as well if we're considering that someone may be abusing anabolic steroids. And some of the physical effects might be obvious, or some of the complaints that someone may list could lead you to look into perhaps it's an anabolic steroid behaviors as well. There's some of the resources here. I would imagine that those are available for you to come back to if you're not going to make a note of it now. The NIH.gov, Medline Plus up there for a lot of this information. Ken's site, Verizon.net, he has a lot of stuff there. He used uppers, downers, all-arounders as a source of some of the pharmacology information. And then my book and website listed there, where I get into a lot of the pharmacology and description of some of the effects of these drugs. And again, as an overall picture, how to view them and look at them as big categories and what to expect within each of these categories when a patient would present to you. So I mean, that is all the information to present, and again, I'll be glad to answer some questions that we would have out there.
Okay, hi Mike. Yeah, I do have some questions that have come in and some left over from the first session. Since it is about 3:30, I just want to say if people do have to leave, that's fine. This webinar is being recorded and will be at our on-demand library site by tomorrow. And everybody who's attending will get an email with CEU and certificate information. Is also information about linking to the website and an evaluation. So if you need to leave, feel free to do that, and you'll be able to hear this webinar on demand tomorrow. Here's the first question. How long after discontinuing opioids do the social behavioral effects last? Are any of these permanent?
Now, let's see, what did we look at there? Bear with me a second. It all depends on, again, an individual's case and what they're doing in the meantime to change these situations. Lack of motivation, unemployment, lack of education, crime, family dysfunction, lack of anhedonia, again, lack of enjoyment in other activities. And that is, for NA group meetings or treatment or group attendance or partial groups or getting to work, and all of the activities that can bolster or support someone's recovery will allow their systems to begin to rebalance and stabilize without the opiate. How long? You don't want to get overconfident. Someone who may seem to be raring to go at a couple months could be deceitful. Someone who takes their time and it seems like it's taking them too long might take too long. But when someone is in that recovery, early recovery, and then it goes into months where, we're doing a little better, how slow do we need to go? Can we jump at it? As long as they are doing what has been laid out for them to do, and they are in touch with support systems that can help them get through, say, a craving situation, which may still arise here and there for who knows what reason. It could be, it could be several years before someone can actually say to themselves, I feel pretty good, I feel pretty normal now, but I don't know if it's because I'm still doing A, B, and C, or do I need to do that anymore? And a lot of people have been so ingrained in the social network then that they just maintain that because that's what they do now. So it's hard to determine a timeline, but yeah, the basic functions will return. It could take quite a while, longer for one than another, but it's not going to happen without integrating and introducing alternative activities and stimuli to occupy the brain to start utilizing the brain for what it needs to do and experience reward and start utilizing higher functions by engaging in the drug-free appropriate activity as the stimulus for this brain activity instead of the drug. So yes, it's possible, but it could take quite some time for certain individuals.
Okay. When a client is on methadone, how effective will Percocets be in someone who is prescribed this medication for pain?
Depending on the dose of methadone, if it's a moderate dose, which might be 70, 75 milligrams a day or lower, a Percocet for pain could possibly still work. If we've got a true situation that is causing a pain response, it's going to work. That person may require a higher dosage than another person who's not on methadone. And if someone is on a very high dose of methadone, the oxycodone may not get to the site where it needs to get because there's nowhere for it to go to work at. So it may not do anything. The methadone itself on a high dose might eliminate some pain response. Then again, someone may become hypersensitive and have a higher experience with the pain. And so the Percocet may then do something. There's no way to know for sure. It all comes down to, the pill-taking behavior. If this person, if you want to avoid that with them, then certainly do not give them a pill. If they feel like it'll help them and they're on top of their recovery and there could be a psychological component to taking the pill and helping with some pain for a couple of days, but then definitely stopping the medication. So chemically speaking, it could help. It all depends on how much methadone is in someone's system, or it may not do anything. Quite honestly, a Percocet may not be worth putting into someone's system and causing any pain relief.
What is synthetic marijuana?
Synthetic marijuana is a chemical that was devised, I'm not sure how many years ago. It's been a little while now. But it is a chemical that was being developed for legitimate purposes that kind of got out of the bag. And it is similar to THC chemically, but just like 150 years ago, or we won't go that far back, let's just say 120 years ago, where we took the morphine molecule and kind of played with it in a lab and got heroin and then ended up getting oxycodone and oxymorphone. Well, they took the THC molecule and they messed with it and they got a chemical similar to THC, but not quite. And it is just a synthetic analog or cousin to THC. And it's produced as a liquid that is put into an apparatus to spray over any type of a leafy or vegetative substance that could be passed off as something that looks like you might want to smoke it or use it as incense. So it can be marketed that way, and it's smoked to burn the sprayed chemical on it and inhaled and gotten into the nervous system as a drug similar to THC. Much more potent, higher degree of side effects, and does not last as long as the THC effects do. So anything that's more potent usually doesn't last as long, especially with an inhaled drug. So here we've got something that is much stronger, more potent than THC, that is smoked, has a very strong initial effect, but then doesn't last as long. And then there are other side effects, headache, bizarre thoughts, convulsions, hallucinations, all of that kind of goes with it when someone takes too much of it.
Okay. Somebody did send information about FASD. It says you could find information about drug and alcohol use on the FASDeducation.org site. There are regional centers around the U.S. and always willing to pass on research to anyone who is interested. CDC and NIH also have information on the topic of marijuana, along with other drugs and fetal effects. So we have that location again is FASD Education, all one word, .org. Okay.
All right, thank you.
Now here is, let's see. I received CD training during the early 90s and was taught at that time that marijuana was literally killing brain cells. Is that statement still accurate, and does it apply to all hallucinogens or just marijuana? Is this the primary reason marijuana hasn't been legalized as of yet?
Killing brain cells? Yeah, hallucinogens and marijuana itself can cause the brain cells to operate differently, and they can, just like any of the other drugs, they can tune them to work differently where they are not processing neurotransmitters properly. And over time, you will kind of squeeze the life out of some of these cells so they really don't react to the way they're supposed to. I wouldn't call it neurotoxic. They don't kill the cells, but they kind of render them useless in some respects, especially over long-term use. So we're making the drugs, or I'm sorry, the nerve cells operate in an exaggerated state for too long, or then they are not able to operate normally. So they're not killing as in a toxic, neurotoxic sense, but they are certainly misaligning them. And when you get into the complexity of the brain and you're really affecting certain parts of the brain that are responsible for these neurochemical productions, that leads to a network into the rest of the brain that relies on these neurochemicals to operate. So the development, if we're at that age, or the skills necessary to incorporate larger areas of the brain or higher centers of the brain are compromised as well. So those are the long-term effects that marijuana use or some of these hallucinogens would have over time by really complicating and interrupting the network of communication in the brain. And the legality of it, I think, goes further back than that, and that's a long, complex story in this country as to the illegality of marijuana and what it's truly based on. And that's something that it's a fascinating subject to look into, and how we got to this point and how we're questioning, is the legality something we were going to live with or not. So that's an interesting story if anybody really wants to look into that.
What are the long-term physiological effects of methadone on individuals who have been in a methadone program over 10 years?
Long-term physiological effects, the physiological long-term effects of opiates, like our one slide here said, that it's not that, they are not that toxic to the brain and body. So, there's been people on methadone 25 years or plus where, some of the physiological effects are not all that recognizable or that apparent, that's being on an opiate for a long time. Their nervous system function, all the stuff we're talking about, is going to be dependent on that opiate, and that's the real issue. Can they ever get off of it at that time? It would probably be more difficult for someone who's been on it 10 years to get off of it. They're kind of in a state where, you know, their nervous system function is kind of dependent on this chemical to keep it in balance, and they may need more as time goes on. But as far as long-term physiological effects, I'm hard-pressed to come up with anything that's worth mentioning in a toxic nature. Long-term GI effects, constipation, you know, some of the impactions that may happen, you know, the body may adjust to that if the dosage is proper. Arrhythmias may happen with methadone or long-term opiate use. We've got to watch out for some of that. That's something that needs monitored, I would say. Their heart functions. The liver has to process a synthetic chemical over time, so liver enzyme testing might be necessary. You might see some loss of liver function. Really not much more to report on there from my experience, and that has been why methadone has been, you know, kept on as the drug of choice in that, and utilized and approved because of its lack of long-term physiological effects.
Earlier, you answered a question about, let me find it now, the effects of antidepressants if a patient is taking opiates. The follow-up to that is, couldn't the depression actually be caused by use of the opiates?
The depression? Oh, certainly. Yeah, that's the dual diagnosis challenge to determine what's going on with someone. If, yeah, we mentioned the effect, the situation where someone who was depressed started using opiates and masked their depression, and then when they're in recovery, they recognize the depression again, and we're back to that. But yeah, the use of opiates for someone who may not have had a clinical depression diagnosis or that potential, and then went ahead and used opiates, yeah, the situation could result then where they have developed a clinical depression because of the chemical changes, the biochemical changes that have happened over the years, over time, because of their use of opiates, certainly. And now we've got a situation where they are depressed, and now the use of an antidepressant could help them in their recovery from opiate abuse. Yes, certainly.
Okay. When did the empirical literature that marijuana is physiologically addictive happen?